I showed this slide yesterday because, as you know, by the time that a woman hits 40, a young woman, the probability of developing an invasive cancer is really about 2%, but that most young women will survive their cancer. So if you look at American Cancer Society numbers, there are more than 14 million cancer survivors, of which there are about 350,000 young adults who are female. And so actually this is a significant population in terms of the young adult reproductive aged population, but by the same token, this particular demographic represents about 5% of the cancer survivor population. And so for aspiring epidemiologists like myself, they're very limited numbers at single institutions, and we really needed to find an approach to go beyond this if we wanted to look at reproductive outcomes in this population. So this is a busy slide, but to date there are several well-done, large, either retrospective cohorts or registry studies, starting with Byron's study on top, 3 bigger studies on childhood cancer survivors, to the Childhood Cancer Survivorship Study, to the British Childhood Cancer Survivorship Study, of children who were diagnosed at this point a while ago, mostly comparing to sibling controls to look at some of these pregnancy outcomes, mostly as pregnant, not pregnant, infertility, not infertility. Similarly, when you look at young adult cancer survivors, there are registry studies from Norway, as well as an additional study looking at Hodgkin's lymphoma trial participants. These are some of the bigger studies, and I'll spend a little bit of time telling you about at least what we've seen of the work done with the California Cancer Registry. And I think that the bottom line from these larger studies has been, we know that pregnancy is less likely in a cancer survivor than her sibling or the general population. And we have a sense that the risk of adverse reproductive outcomes, of course, really varies by the type of cancer you had and also the type of treatment that you had. But with this, there are very many unanswered questions that you can't get at with a registry study or with a retrospective cohort design. We think that there are gaps in knowledge, and we lack contemporary prospectively collected data on reproductive outcomes in this population after young women are exposed to gonadotoxic therapy. And these are just some of the areas that we together in the group that I'll show you have postulated. We think that we don't know much about who's attempting pregnancy, how long is it taking to become pregnant, what are some of those barriers. We don't have a good sense of family planning access in unintended pregnancies in this population. There's one study out from Norway looking at the registry by way of looking at terminations of pregnancy. We don't know much about the process of reproductive aging. We can kind of show you schematics of what we think happens to ovarian reserve over time, but we actually don't know. And then, of course, there are disparities in psychosocial outcomes related to reproductive capacity, for which we haven't collected data in a prospective way to see how that changes over time in survivorship, and if there are really any points for intervention from us. So with that in mind, this pilot grant was aimed at trying to initiate a national fertility preservation registry to take a look at some of these outcomes of interest following exposure to gonadotoxic therapy. And then for the first year, we wanted to do something simple and to answer, well, what are the capture rates to this cohort study? We knew from the start, and I know that Matt, can definitely talk certainly about this to much more extent than I can, that there would be challenges with trying to recruit young adult survivors, right? Because they undergo a variety of physiologic, psychologic, growth-related changes that makes it particularly hard to recruit this population to research. And so these are sort of 2 scenarios for what we've seen in the literature. On the left, you have the Childhood Cancer Survivorship Study, which, as most of you know, recruited from institutions, so that patients and their siblings were recruited from the institution from which they were treated. These guys were diagnosed between 1970 to 1986, and at the time of study were between 15 to 44 years old. And this is how they did. So of 20,000 potential participants, and this is male and female included, when all is said and done, they recruited 5,100 young women. So of this population originally, you lost about 15% from follow-up. There's another 15% that declined and about 13% that went ineligible. So really they recruited about 57% of those eligible women. And so this is a really, I think, a demonstration of pretty optimistic numbers. When you look at the California Cancer Registry study, this was a select 5 most common cancers in women of reproductive age who were diagnosed between 18 and 40 in California. They were diagnosed between 93 and 2007, and at the time of study, they were also between 15 and 44, and this is how they did. So you had originally 6,700 women who were eligible in the registry. From that registry, which should be a population-based sample, you lost 62% from loss to follow-up straight away. Another 17% had no response, and 5% declined. And so although the sample size is great, it's 1,000 young cancer survivors who wouldn't want that, really this represents about 16% of those eligible. And so when we start looking at these types of studies that we're all initiating, it will be important to think about what selection bias went into your sample, and that will also be a limitation of our study. So understanding this, we wanted to initiate this particular protocol, and this also was meant to be a pilot to see whether a clinical protocol that is sort of more open could potentially be disseminated through the National Physicians Cooperative. The Fertility Information Research Study, the first registry, is a prospective cohort in terms of the study design. We wanted to be really broad in our inclusion criteria in order to be able to then dissect out subsets of patients and hopefully ultimately have more generalizable data. And so we opened to anyone who had either a cancer diagnosis or fertility-threatening treatments, female, and ages 18 to 44. The study procedure could have gone 2 ways, whether one was to actually obtain IRB approval at each institutional site, but really we felt in really taking into account some of the experiences from teratogen registries, we have a single site IRB at UCSD, and so the process that I'll show you is essentially patients get referred in from different sites, different sources for verbal consent with our coordinators. That verbal consent brings them to either a telephone or web-based questionnaire on their reproductive outcomes that they'll answer until they're 50, and then we subsequently obtain written consent and medical record release so we can get at, in better detail, what their exposures were. And so as a pilot project, this was done in collaboration with friends and family programs of the NPC, and this would include USC, Penn, the University of Washington, Alabama, Chapel Hill, and Northwestern, and our reproductive epidemiologist, Brian, at the University of Massachusetts. So altogether, we put together an instrument over multiple phone calls and in meetings at ASRM, where we took domains of interest, which included cancer and treatment history, your medical history, physical measurements, demographic data, and these really instruments came from standard literature searches. We looked at health habits. We definitely had nice questions on menstrual and reproductive history from healthy aging, family planning questions, contraception questions, time to pregnancy questions, fertility preservation questions, decisional conflict, social support, and depression. And so this is the instrument from the initial intake, some of which we will keep in our ongoing cohort annually. But essentially, ultimately, this instrument takes us about half an hour for a patient to go through, whether it is through the phone or through a web-based format. This is how we envision recruitment. We envision that potential participants who either called into the FERT line, was referred into the FERT line by an oncology program or by an NPC fertility preservation program would then be asked if they would be interested in being followed longitudinally for reproductive outcomes, and once yes, they would enter into the registry. And what we found, which I'll show you, is that actually a lot of the cancer survivorship groups with folks like Matt Zachary or folks like Alice really helped us out in terms of reaching out to this difficult to recruit population. So at the level of a single institution, we all went out with our brochures and with our talks to talking to cancer center physicians, to the care teams to reach out. at many of our cancer centers, there are advocacy groups that have a lot of community outreach, and so that was another way for us to be able to recruit these young patients. We did student listservs from medical students to undergraduate students at our own institution, at local institution, and then obviously the patients that we each saw for fertility preservation. Locally, we went to the Children's Hospital, the oncology areas, and really went through the same type of recruitment strategies, student health to any university that would answer our emails, newspaper ads at local universities, and actually Craigslist ads. We thought that we kind of realized, actually, this population spends a lot of time getting their information not from their physicians, but out in the virtual world. And so that's when, through folks whom we've met through this consortium, really reached out to cancer survivorship groups. We've been to local meetings of local chapters, as well as really the national posts. And from the bulk of our recruitment, as you'll see, really ultimately, no matter how much effort and outreach you go out to teach others, comes from those who are most invested, so our own patients, and then those who have become involved in wanting more information through cancer survivorship groups. So this is partly how we've done. In the past year, we started overall with about 400 potential participants, and so this is combined from the different approaches. And you can see that once you reach these participants, very few declined, most people consented, and so our first pilot data set is based on 237 women who completed the questionnaire as of May. So this is kind of where I derived the talk from. We see, this is a graph looking at the number of potential participants over the sources that they came from. And so I told you at the beginning that this was really a pilot off of some NPC sites. And so you can see that from most of our cooperative sites, of the potential participants who come into the registry, most of them are actually consented because most of them are really patients of ours. From the FERT line, the accrual rate was much less, but you can see that actually a good 2/3 of the participants came from social media. And so this is an example of some of the work that we did with the Stupid Cancer group. And so we've done a total of really 5 posts in this. For all of you who are on Facebook, you know that a Facebook post takes maybe a second to sort of post up there. It's a 2-liner, but that then blasts across everyone who is associated with your site. And so with the first post back in September, we had, and looking at the blue line, 20 some odd responses, but with each subsequent post, it's exponentially increasing. And so literally, I think within the first hour after each post, you get just a massive stream of email coming into our coordinating sites. And as I was learning about this from all of our coordinators, I think that the interesting thing is not only that your responses are increasing, but because it's also possible for a young survivor to either like that post or potentially to share that post with other people with whom they're friends, with other groups, we saw an increase in shares. And so although, for instance, it's very easy to know that right after a post from Matt Zachary will have 50 responses, but when you actually ask these 50 responders where they came from, they didn't all come from that website. Some of them came from the shares. And so I think this is a first demonstration, at least for me, for what a powerful tool this could be to get at this community. We learned something about how to contact these patients because unlike anonymous web-based surveys or a one-time web-based survey, we need written consents from these patients and we need their medical records. And so that's why we needed the verbal consent and to be able to actually have multiple contacts. And you can see that our coordinator has tried very hard over this year to get at all of these 400 first participants who called, or potential participants. And somewhere around 6 calls or emails later, it drops off. And so that kind of shaped our protocol for the rest of the year. So I want to tell you a little bit about these folks. Of these 237 first participants, they really are a variety of ages. So we're getting all the way down to 18 and all the way as old as 44, as young as 44. But then most of these patients are in their later 20s and 30s. Most of these participants are white, and a small proportion are of Hispanic descent. But interestingly, just by the way that it came, they come from 44 states and 3 different countries, just mostly by the way of these social media outreach. This is a highly insured and highly educated population. Most of these patients have graduated from college, some in grad school, very few smokers, and most are married, but there is a good proportion of those who are single or divorced. By cancer type, I think that this is pretty representative of the common cancers that you would see in this population. Still, the largest, and as expected, would be breast cancer patients, but we certainly have a good proportion of lymphoma and leukemia patients in whom we know fertility is potentially impacted by the type of treatment that they had. Most of the patients are within 3 years of treatment. Some are within 3 to 5 years, and then there's some more, a quarter, who are over 5 years since treatment. Most have been exposed to chemotherapy, and some only hormonal or radiation therapy. And in terms of their reproductive characteristics, very few are at this point amenorrheic. This is accounting, sort of excluding those who are on hormonal contraception. In terms of their prior pregnancy history, the majority are nulligravids, but there's a good proportion who have had prior pregnancies before. But uniformly in this population, patients have a desire for future fertility. And so when we think about the selection bias that came into accruing this population, what type of questions can we answer with these patients? It would be questions directed at people who actually want to attempt or have a goal of future fertility. And 10% of this attempt are attempting pregnancy now. So with that sort of idea of whom it is that we're recruiting, we realize that there's not actually very much information, or really no information out there about patients who are currently attempting pregnancy after a cancer diagnosis, other than some qualitative studies about what it is that they thought about going into attempting pregnancy. So with this, we wanted to explore some of the factors that are associated with who is and who isn't actively attempting pregnancy. Of our smaller number of 22, you can see that most of these patients are in their 30s. This is sort of the first row that you're looking at. But women as young as 18 and older into their 40s are attempting pregnancy. And so this tells us that the bulk of the people who are actually attempting are in their 30s, which potentially raises a problem because their ovarian age or their ovarian reserve age could potentially be much older than being in your 30s, which is relatively young. Most of these patients are attempting pregnancy somewhere at least 1 year out from their cancer diagnosis, but there's still some 3-4 patients who are right after cancer diagnosis and attempting pregnancy. But interestingly, half of these folks have been attempting pregnancy for more than a year, so they technically meet the definition of infertility. But these infertility patients aren't seeking help, because really we know that actually about half of the population saw a fertility specialist prior to their cancer treatment. But in this population, really only 2 of them had, even though the majority of them were really taking much longer than what you would think, in terms of a diagnosis of infertility. So comparing the folks who are attempting pregnancy to those who are not, the age distribution is different. And so that the people who are not attempting pregnancy in general are younger. Interestingly, in terms of race, this is not statistically significant, but it looks like those who are attempting pregnancy are more likely not to be white. And then, as expected, they are in a relationship where they are either married or living with a partner. There were no differences in terms of their menstrual cyclicity in the past year, but those who are attempting pregnancy were more likely to have had a history of infertility, more likely to have seen a fertility specialist, more likely to not any more likely to have undergone a fertility preservation treatment prior to their diagnosis, and were similar with those who are not attempting pregnancy in terms of their prior gravidity. So interestingly, we didn't see any connection in terms of what cancer types that they had, what stage, how long it's been since their cancer diagnosis, whether they've had recurrence or not, what their treatment exposure was, the number of comorbidities, or body size. But this is a small sample, and so we are moving forward in terms of trying to accrue more numbers to try to flesh out sort of not only what are the reproductive characteristics that are associated with attempting pregnancy, but what are the other elements from your current medical status to other sort of psychosocial areas. So what's ongoing? Well, it's a big endeavor to acquire medical records from 260 participants from their original medical sites, however many sites that they went to become to be treated. And so we're in the process of trying to acquire these records and abstracting. We actually have a biomarker pilot because one of the things that's missing in the literature, of course, is that you can know that pregnancy is less likely, but what is that? How is that related to your underlying fertility? And it is, of course, a challenge when you have participants from 44 states on how you would, in a cost-effective and efficient manner, obtain biospecimens in order to measure markers of interest like AMH. We spent some of our funds to build infrastructure because, as you can imagine, you really need, when you have a huge influx of young participants, you need some infrastructure to make this go a little faster. And so our Cancer Center group really helped us to build participant registration or automated links to questionnaires and sends for participant incentives that would help us out. And we're tracking the participants going forward through another program. And in trying to adopt what many of the young people already know, we also started our own Facebook, and this is really meant for cohort retention. So our goal would be, as we move forward, that the results that come out would really come out through our Facebook page so that this would engage the participants on what it is we're doing. So I just wanted to show you some of the web pages of what we've done. And so at this point, we have 5-6 studies open in terms of looking at reproductive outcomes in this population. And so it's easy by participant to figure out which studies that she's in and whether she would be eligible or interested in being consented for future studies. And so with this, we're hoping to really build a bank of potential participants for others who want to look at questions in this population. And other easy things that they were able to do that made our life a lot easier was to really, each row represents a particular participant for a particular year. And so once registered, just emailing the survey or emailing a gift card is easy for the study coordinator. And then, spent a lot of time thinking about what part of San Diego we wanted to represent in our Facebook page, and had one of our young survivors incorporate our ribbon into our own sort of logo for the studies that we are doing. So this is a brief introduction to show you that actually there's some kind of creative and newer ways to be able to recruit young adult cancer survivors from the community to study reproductive outcomes. And so, a limitation, as I've already alluded to, is the selection bias you have from this type of recruitment. But the selection bias exists depending on what type of question it is you want to answer. And the thing about it is that if you decided that you were to do a population-based study on reproductive outcomes, you would have to recruit a whole lot of patients who are not attempting to look at some of these outcomes that we're interested in. And so perhaps this isn't going to be such a limitation, just depends on the type of questions that we would like to ask. I think that we're able to, through this mechanism, really obtain a wide range of reproduction-related outcomes in this population, at first for hypothesis generation and then hopefully for validation. And one of the most important things we'd like to do is really work out how to obtain biosamples for markers that correlate with our outcomes of interest. So as an acknowledgement to Jeff Chang, my mentor and my boss, and collaborators in the effort across the NPC, and our study coordinating team, Tom McDade here, who's working on the biomarker piece with us. This was funded by a pilot from the Oncofertility Consortium, and then I am also supported by the NIH and the American Cancer Society. Thanks.
Thank you very much. A wonderful presentation. Could I ask for questions from the audience? I'll ask the audience question, and I'm curious about the, I think it was about 26 of your patients who are actively seeking to become pregnant, and you had about 32% of those who reported infertility. So that was self-reported information. Was the question, had you been to a fertility specialist, or just you had some evidence of infertility? Because there's, of course, this question about infertility in the young adult cancer group, particularly breast cancer patients.
Yeah, actually the question is that we ask for each time that you've attempted pregnancy, how long has it taken for you to become pregnant? So we derived it from that and not from a self. So that's a really interesting question, right? Because potentially they don't know that that's potentially not normal, and that would explain why post-diagnosis, post-treatment, so few have sought help.
And it was statistically significant, I believe, in that.
Right, they were more likely to have been infertile in the past.
Dr. Quinn.
Hi, thank you for that presentation. That was great. I have two questions. One, and if you said it, I missed it. Were the respondents providing any type of consent? Did they have to consent to this as like in a web-based survey through IRB? They did? Okay. And then two, have you noticed whether or not the answering the questions has caused any distress, and has anybody contacted you and said, now I'm thinking about this and it's, I need some resources?
Actually, no, we haven't. So from the web-based questionnaire, it's hard to tell, but from doing the telephone-based questionnaires, we know that some patients have asked about sort of follow-up questions to the questions that we have posed. And so actually, when you do the web-based questionnaire, and also on the telephone, we direct them to our website from our cancer center, on which we have multiple resources for young survivorship types of resources.
Okay, thank you.
Yeah.